Okay, guys, so now we'll get into some of the fun stuff. We'll get into specific leads. So just remembering again that ECG leads really, again, it's not electrodes, it's just the orientation of our views of the heart, basically. So it's orientation of a positive and negative terminal, or a negative and positive terminal. Just remembering that when we're capturing activity, we're always capturing it in this orientation from negative terminal to positive terminal. Now, our limb leads, we have 3 of them: limb lead 1, limb lead 2, and limb lead 3. So in this example for limb lead 1, we're capturing activity moving from the right arm to the left arm. Okay? So again, remembering our mean vector is still this direction. So while the mean vector is moving in this direction, we'll still capture some signal, because again, there's that horizontal component vector, right? So we'll still get some activity, but the amplitude, right, of those waveforms won't be as loud. The sound won't be as loud because we're not exactly in line with it. We're in line with, we're capturing some of the signal, not all of it. However, if we have an example here for lead 2, it's capturing activity going from the right arm to the left leg. So it's capturing activity going in this direction. Well, remembering our mean vector is going in that direction, right? So again, like we mentioned, if we're going, the more in line we are with that mean vector, right, generally, or the closer we are to the source of our activity, the larger the amplitude will be. The microphone's closer. Yeah, the microphone is closer. So in this example, right, the amplitudes will capture the amplitudes, but they'll be large, and much larger than we'll actually see in lead 1, right? Because we're very much so in line with that mean vector, right? And then the other, right, limb lead, our third limb lead, is limb lead 3, which uses an orientation of a negative terminal here and a positive on the left arm, and then a positive terminal on the left leg. So again, remembering our mean vector is in this direction. It's got a horizontal component and a vertical component. This isn't going to capture really much of any of that horizontal part of that vector, but it will capture a lot of the vertical, right? So it's not going to capture all of it, but it'll capture some of it, right? So it'll still have positive amplitudes, right? Because it's in the same direction generally. It's just more of the vertical component, not the whole diagonal. It will be smaller though than lead 2 because it's again not exactly in the same direction, right? But it's capturing a piece of it, a piece of that vector. It'll be larger than lead 1 because of kind of the orientation of that positive terminal. Remembering we're saying the positive terminal is kind of the eye, right? It's the receiving end of that lead, right? You can think of this as the receiving end of our recorder. The bottom of the heart, right? We're going to capture more of that inferior wall. There's more mass there, right? Versus looking at the free wall or the lateral wall of the heart, right? So again, lead 3 will be larger than lead 1 because it's capturing a larger amount of cells that are producing activity in those ventricles, right? So it'll be smaller than lead 2 because it's not in the same direction, but it'll be a little larger than lead 1, even though it's only capturing some of that vector as well, but the part that it's capturing is producing more activity. So lead 2 is the largest because it's not only indirectly in line, its positive terminal is also on the bottom. So it's got both capturing a large piece and directly in line with that mean vector. Whereas, lead 1, right, isn't capturing a lot, and the part it's capturing is smaller, right, in terms of the sound it produces or electrical signal it produces. Lead 3, for example, is, while it's only capturing a piece, that vertical component, it's capturing more of the inferior wall, the positive terminals below the heart. It's looking at the inferior wall. So it's going to capture, which is a larger structure. The sound's going to be, or the signal is going to be a little bit larger, right? So again, just think of those signal capture properties we talked about. So again, now people will ask, how do I have to place multiple electrodes here? Now, the key thing to remember is leads, again, are not electrodes, right? They are orientations of a negative terminal and a positive terminal. What we'll see on an ECG setup will make more sense. Usually, we'll just place electrodes 4 on the heart, and depending on which look we want to take, we can switch one electrode with our machine from being the negative terminal to the positive terminal. This will make more sense in a bit. So again, this is our limb lead. So again, limb lead 1, capturing activity right arm to left arm. Limb lead 2, right arm to left leg. Limb lead 3, left arm to left leg. So this is getting more of the more of the horizontal component and the lateral wall. This is getting kind of, it's in line with that vector. And then lead 3 is more the vertical component and capturing the inferior wall as well as lead 2. Lead 2 we'll often see because it's so well in line and looking at a large piece of the heart, will be often used as our basic monitoring purpose. And a little interesting fact, if you add the peak amplitude of the R wave in lead 1 to lead 3, it usually adds up to lead 2. So you add 1 plus 3 usually equals 2. Interesting. So then we have our unipolar or precordial leads. And again, it's really important because remember that distinction, lead versus electrode. The unipolar leads actually only technically use one electrode, and they use one true electrode to make up that lead. They don't use, there isn't a true bipolar setup with the leads. So again, just remember, leads are orientations of terminals, not necessarily electrodes. So they're placed in stereotype locations, so V1, V2, V3, V4, V5, and V6. There's where we place them on the chest. This is helpful because it gives an idea of kind of what we're looking at. These leads are capturing activity coming out in the transverse plane, right? In the transverse plane. And these are really helpful because, again, remembering that electrical activity of the heart is 3-dimensional, and we might want to look at some of that transverse, get a transverse view, right, of that electrical activity. Look at what our structure is doing, kind of in the septum, or really just giving us a greater resolution of the activity that's happening in the heart. So V1 is going to look more at the septum, and V2. V3 is going to look more at the anterior wall as well as V4. And then V5 and V6 are going to look more at the lateral wall. So again, these are great because, again, they give us a transverse slice of that activity. So again, it gives us a little bit more resolution to the views of the heart or what's kind of going on in the heart. And again, they accomplish this by just placing a single electrode. So for example, if we wanted a V1, we'd have to place all of those 4 limb electrodes, right arm, left arm, right leg, or lower side. We don't always put it at the leg. We put it kind of on the abdomen. And then we would place a single electrode for whichever precordial lead we want. So if we want V1, we would place it on the right fourth intercostal space. If we want V2, and so on and so forth. So depending on which unipolar lead we want to look at or have available to us, we can place an electrode to create that terminal. All right, and then we've got our augmented leads. which technically don't really have a true positive or a negative electrode. The terminals for these leads, again, leads are orientations of terminals and views of the heart. These are based on the orientation of our 12 lead setup, right? So when we want to get 12 views of the heart, we actually place 10 electrodes, and then we can produce these augmented leads based on the orientation of these other electrodes. Now, there's 3 of these augmented leads: AVF, AVL, and AVR. AVF, you can think of augmented lead foot or inferior, right? It's going to look at the positive terminal is going to be at the foot. It's going to look at the inferior wall. AVL, lateral, all right, where a positive terminal is going to be here, right? Again, we're capturing activity in this direction, but the positive terminal is our eye, so it's going to be capturing the lateral wall. AVR stands for, you can think augmented lead right, right? So we're going to place our positive terminal on the right side, our negative terminal here. It's going to capture activity going in this direction. And again, these are produced by a component or composite of these other electrodes that we've placed. They don't have a true one. Even like the unipolar leads, which we just place a single electrode to create a positive terminal, these don't actually have any true ones. It's just produced by the orientation of all 10 of those electrodes used for a 12-lead ECG. Now, you might be wondering, well, what happens with AVR, right? It's capturing activity going in the opposite direction. Well, that is correct. It's looking at the right side of the heart, as we see here, right? Because again, our positive terminal is our eye. And you'll see here the view is inverted. Well, like we mentioned, if we're capturing activity in the same direction as the activity is produced, the waveforms on the ECG will be positive. If we're capturing activity moving away or in the opposite direction, like we do here, they're going to be inverted. It's going to be flipped. We have an inverted view, basically, because we're placing the electrode, the terminal, the positive terminal on the right side, and activity is occurring in this direction, yet we're capturing activity oriented going in this direction. So the view will just be inverted, right? It'll look similar, but just flipped, because our orientation of our lead, our capturing signal, is opposite of the way or the direction of that vector. So AVR, call it the orphan lead because it's the only one that is looking at the right side. Now, we'll cover just briefly the setup for these ECGs or stereotype ones. So you may often see a 3-lead ECG uses 3 electrodes: right arm, left leg. Again, people mix this up, leads and electrodes. It's conflated all the time. Again, leads are orientations, not electrodes. The 3-lead ECG does use 3 electrodes, though, at least a right arm, left arm, and left leg, and it will give you the ability to capture all 3 limb leads, but typically you're only going to be able to capture 1 at a time. So it's a setup to give you 3 leads, because you can capture, you can make this your negative terminal and make this your positive terminal using your device, and you'll get lead 1, limb lead 1. Or you can make this one the negative one and this one the positive one. You'll get limb lead 2. Or if you want limb lead 2. Oops, sorry about that. All right, sorry about that. So, like I mentioned, we can capture lead 2 following this orientation. We can capture lead 3 following this orientation. If you wanted to make this, we can switch this on to the negative one and make this one the positive. So again, our leads just give us different views depending on how we want to, make whichever electrode the negative terminal or the positive terminal. Or in some examples, like our 5-lead ECG, for unipolar leads, we don't actually have a true positive and negative terminal. We just have a positive terminal. So the 5-lead ECG, and for creating unipolar leads. So in the 5-lead ECG, we do use 5 electrodes. It's where things get confusing again. We'll use our 4 limb electrodes, right? Or should probably make this a little bit clearer myself, but we'll often see this conflated too. Our 4 limb electrodes, right arm, right leg, lower leg, and then a single chest electrode, right, or lead. All right, so here we've got V1, right? So again, 4th intercostal space, right parasternal border. It's going to give us that septal view of the heart. So this will commonly be used in acute care because we can get simultaneously, usually with a 5-lead ECG setup, we will be able to get our 4 or 3 limb leads, 1, 2, and 3, and then a single unipolar lead. This is great for acute care because we can get a higher resolution of the heart because we're looking at multiple images basically at the same time. And again, it only gives us technically 4 views and uses 5 electrodes, but we call it leads. You'll see that often referred to in the in practice, but technically it's only 4 leads and 5 electrodes. And then we can move this chest lead, right, to a different location to give us a different lead. So we can put this here, get V6, put it here to get V2, and if we want to look at different views. Now, then a 12 lead, this is where things get really confusing, right? We use only 10 electrodes, but we get 12 leads, right? So again, leads, electrodes aren't exactly the same thing. For this, we'll place our 4 limb electrodes, right? So right arm, right leg, lower leg, right? So we'll be able to get, if we have a device that can run all 12 different signals at the same time, we can get our 3 limb leads, 1, 2, 3. We can get all 6 of the unipolar leads, right? Because these are all just created by each individual electrode we place. So we place one here, we're going to be able to get V1. We place one here, we can get V6. So we've got 10 total electrodes placed, right? Because the unipolar need the 4 limb ones too. And then because we have all 10, the 4 limb, the 6 unipolar, it allows us to create those augmented leads. So we get 3 additional leads. Again, remember we have that AVF foot, we have AVL, and then we have AVR as well. So we have 12 different views of the heart. This is great because it gives us multiple different views and duplicate views of the same region, right? So we can get a very high resolution image, basically, of the electrical activity from the parts of the heart. And again, this is primarily looking at the left ventricle, right? Because given how we've oriented the heart, but that's super important. Again, it's the structure for looking at how we're pumping blood and perfusing our body. Now, you might have noticed that we have some redundancies. Like I mentioned, there are certain views that look at different parts of the heart, right? So again, our V1 and V2 look at the septal regions of the heart, right? Given how they're oriented. Go back to this one. V1 and V2 look at more at the septum. V3 and V4 look at more of the anterior wall. 2 AV, 3 AVF look at the inferior portions of the inferior wall of the heart, and then limb lead 1, V5, V6, and AVL all look at the lateral wall. So we can get multiple redundancies to look at the same area, which is great because to really confirm something being abnormal, we want more than just one view at something. That's why 12-lead ECG setups are so valuable for diagnostics because we get multiple different views of the same area. So we can be pretty certain that if we see changes or abnormalities, they're probably present. The great thing is too, because we know these different leads look at different walls of primarily, again, the left ventricle. We also know what arteries perfuse those walls. We know the LAD perfuses the septum. We know it perfuses the anterior wall. So if we see changes in either V1 or V2 or V3 and V4, we can almost be certain that the LAD is probably involved or blocked or occluded. Right? This gets very useful. That's why ECGs are looked at in the emergency room, right? Because if we see changes, ST depression or elevation or T wave inversion in these leads, we can already have an idea of what coronary artery that we want to look at first. Same thing as two, which in those examples would be the LAD. Same thing would be true if we saw changes in limb lead 2 and 3 and AVF. Well, those look at the inferior wall. We know that's fed by the posterior descending artery, which we know most people is fed by the right system, right, the right side. And then if we see changes in, limb lead 1, V5, V6, and AVL, that's the lateral wall, again, of the left ventricle. And that's fed by the left circumflex. So we know these leads fall within, look at these same areas, again, according to how those positive terminals are placed. And then that gets super helpful because we know generally what may be involved, because when we start having changes to those certain areas, we'll see, or ischemia, we'll see abnormalities on the ECG, and then we can, follow that up with, an angiogram and start looking at, well, is that vessel occluded or not? So again, knowing these leads, knowing what walls of the ventricle they look at, and then knowing the corresponding coronary artery that fuels it is really helpful. And then we start working maybe in the clinic or in an inpatient setting, and you maybe have a patient who has had ischemia in the past. You might be able to see, still see some residual changes in those corresponding walls. So if they had maybe an old infarction to somewhere in the the lateral wall, you might see some changes, pretty persistent on those limb lead 1, V5, and V6 and AVL. So that's all we have for leads. Next, we'll start getting into how do we analyze the ECG.